Hello, in this lecture on cardiovascular disorders, I'm going to be talking about a variety of different disorders relating to the heart. Before we get into that, we need to review some important normal anatomy, including the walls of the heart. Here's a cross-section of part of the heart here. You can see how it's shown. And we have different layers that make up the heart. And we can look at it from most interior to most exterior. So really from here to here. The endocardium, this is the most inner layer. Remember that our blood vessels, or the area that blood comes into contact with on our blood vessels, is called the endothelial layer. And so the endocardium is really endothelial tissue, which is a specialized type of epithelial tissue, and it's continuous with the blood vessels, which should make sense. It also will form the heart valves, which we'll review a little bit later, but the valves allow for the one-way direction of movement through our heart. The endocardium is also going to protect the myocardium, which is the muscle layer of the heart, from any direct contact with blood. The myocardium is the muscle layer. Myo means muscle. It's the thickest layer, and you can see how thick it is in this image. And it's this muscle, as we know, that's going to contract to push blood onto the next chamber or out of the heart. It's going to compress the chambers with great force in order to get that blood to move from one chamber to the next or out of the heart. The pericardium, peri means around. This is the more outer layer here. So we have the pericardium all through here. And we have a couple different layers of the pericardium that are separated by a space. And I'm going to jump to the space for a moment that we call the pericardial space. And it contains just a little bit of fluid, almost like a teaspoon of fluid, that is going to help prevent friction as the heart moves. The pericardium that surrounds it is a more tougher material, but it's loose fitting. And it's loose fitting so that there is some room for movement. And it's going to protect the heart against friction, allowing for movement as it contracts. Now we're going to start by looking at diseases that can affect that pericardium, that outer layer of the heart. Pericardial disease is most often a manifestation of another disorder. So somebody could have an infection or have had trauma or surgery, or maybe they have some sort of growth that leads to some disease of the pericardium. In addition, disorders such as uremia, which is a buildup of toxins in the blood. So normally the kidney would help get rid of toxins in your urine, but if they're not filtered through the urine for whatever reason, they can build up in the blood. Those that have rheumatoid arthritis, which is an inflammatory disorder affecting the joints, some people can also have other areas of the body affected as well, including the heart. And then systemic lupus erythematosus, or SLE, or lupus, is a disease where the body's immune system attacks its own tissues and organs. And so this can lead to the body attacking the pericardium. In any case, it can lead to inflammation of the pericardium, and we'll talk about the different forms of pericarditis that exist. Itis means inflammation. Some people will have an exudate that develops that can enter the pericardial space. An exudate is just a fluid that leaks out of blood vessels and into nearby tissue, and it can consist of a whole bunch of different substances. So there are different forms of exudate. Those with pericardial disease can have clinical manifestations that resemble right heart failure. Exercise intolerance, shortness of breath on exertion, feeling very fatigued, losing weight, edema or swelling throughout the body. If there is a backup into the venous circulation, that's where we would see edema, jugular vein distension, congestion of organs such as the liver, and lower blood pressure. Pericardial disease will impact the heart's ability to function properly. Pericardial disease we spoke about generally on the last slide, but we're going to now look into the different forms acute pericarditis, constrictive or restrictive pericarditis, which is almost like a chronic form, pericardial effusion, and pericardial tamponade. Starting with acute pericarditis, acute means it comes on suddenly. It is inflammation, that's the itis, inflammation of the pericardium, and the majority of causes or the etiology is idiopathic, so unknown cause. In other cases, it can be due to viral infections. For example, those with HIV can develop acute pericarditis. So it's a common cardiovascular complication of HIV. Another example for you is a virus such as the SARS-CoV-2 virus that causes COVID-19. This virus can also cause pericarditis in some people. It is something that develops suddenly, that's why it gets the term acute. And what's happening aside from inflammation is there could be some roughening of the pericardial membranes. So looking back here, remembering that outer layer of the heart, we have this outer part of the pericardium and this more inner part, and then the pericardial space. So it can become inflamed and rough and not be able to function properly. In a lot of cases, this will resolve, but if it progresses, it can lead to one of these three types of pericardial disease. Restrictive or constrictive pericarditis, unlike acute pericarditis, this develops gradually. So acute is suddenly, and this one develops gradually over time. And that's because there are a number of changes that are occurring within the pericardial tissue that takes time. Oftentimes the cause is idiopathic, not known. But what's involved with constrictive or restrictive pericarditis is there is the formation of fibrous tissue, so it's like scarring, and the presence of calcifications. And whenever we have that present, as we've talked about in class before, it's going to make it a stiffer tissue that's not going to be able to function as it should. So it becomes, instead of this loose fitted covering, it becomes this hardened shell that encases the heart and sort of constricts it and really restricts the normal movement of the heart. Pericardial effusion. If we go back to this slide and we look at the pericardial space where we know there should just be a little bit of fluid here that helps prevent friction, what we see with pericardial effusion is that there's an accumulation of fluid within the pericardial cavity, and the fluid is usually an exudate. And I mentioned on the last slide that an exudate is a fluid that leaks out of blood vessels into nearby tissues or into an area. And the exudate is going to contain a bunch of different things. There are different types of components that can be within exudate, as I already mentioned. But for example, there could be cells and proteins and other materials. And in a lot of cases, it's a pus-like material. Pericardial effusion does develop suddenly, so this comes on very quick. And we know it can result from somebody having pericarditis. We talked in particular about acute pericarditis leading to pericardial effusion. Now, if fluid were to accumulate kind of gradually, the pericardial space would be able to accommodate this extra amount or this accumulation of fluid. But if it accumulates very quickly, then it can lead to compression of the heart, a condition called pericardial tamponade. So in other words, if the fluid in that pericardial space increased gradually, the heart may be able to adapt. The pericardium can adapt to that increase in fluid. But if it happens quickly, if that effusion happens very fast, it can't adapt quick enough, and it can fill up so much that it actually compresses the heart. So let's talk about tamponade now. Tamponade or pericardial tamponade can result as well from pericarditis, as we talked about before. And with this condition, you're getting so much fluid that builds up so quickly in the pericardial space, it can't be accommodated, and it leads to compression of the heart, which restricts the heart's ability to pump. Now, of these two forms of pericarditis, And really both can end up causing effusion and tamponade. We talked a little bit more about acute pericarditis and its relationship to pericardial effusion and pericardial tamponade. Because acute pericarditis is the most common form of pericarditis. So we could say that this form is more rare. All right, let's have a look at what might happen if somebody has acute pericarditis and it leads to pericardial tamponade and/or constrictive pericarditis. As fluid continues to fill this pericardial space, it's going to cause an increase in the amount of pressure within here, which is going to put pressure back on the heart, causing cardiac compression, as already discussed. And so as this pressure is exerted onto the heart, that pressure is going to approach our normal diastolic pressure, which is our filling pressure. We need an appropriate pressure to allow for our chambers to fill with blood during diastole. This is likely going to impact the right atria first because it's under less pressure. It's easier to reach that pressure from that pericardial fluid around here. And so it's going to reduce the ability of that atria to fill. This is going to create pressure changes now where we're going to have a reduction in how much blood is actually returned to the heart, venous return. And so if it's not returned to the heart, we know it's going to back up and it's going to cause systemic venous congestion. Continued increased venous pressure can lead to right heart failure and peripheral edema, as talked about in class. So on an earlier slide, I had mentioned that pericardial disease can present in terms of some clinical manifestations similar to right heart failure. And that's because the right side of the heart is under less pressure overall because it only has to generate enough pressure to fill and then be pumped out to the lungs. And so it's easier for the pressure developed in here to approach the pressure of the right side of the heart. So these are the signs and symptoms that will come on first. However, pericardial disease can have both signs and symptoms of right heart failure and left heart failure in those that are affected. So a reduction in atrial filling then is also going to naturally reduce ventricular filling, which means we're going to have less blood pumped out with each stroke or each contraction, so a reduced stroke volume, and therefore a reduced cardiac output. And shortness of breath is a common occurrence. So we've spoken about that outer covering of the heart, the pericardium, and that pericardial space in between. Now we're going to look at conditions of the myocardium, the muscle of the heart. And cardiomyopathy is the more appropriate term, referring to really a diverse group of diseases that can affect the myocardium or the heart muscle. Cardiomyopathy can result from ischemia, where there's a reduction in flow of blood to the heart, and this is a very common cause of cardiomyopathy, especially when it's in conjunction with high blood pressure. Another cause is cardiac remodeling, where the heart actually has to remodel itself because maybe somebody has had sustained hypertension or a myocardial infarction where the heart has to work harder and it undergoes hypertrophy. That is a form of cardiomyopathy. In other cases, somebody could have an infectious disease and then secondary to that, they develop cardiomyopathy, almost like they have a cold of their heart. Inflammation of the heart causes weakening of the heart walls, which affects its ability to contract properly. And then good old idiopathic causes where it occurs for an unclear reason. So let's look closer at that myocardium, that muscle layer that we know is the thickest layer. We know it contracts to push blood from chamber to chamber, but also out of the heart. And it uses great force to do that. In some areas more than others. So for example, the atria have the thinnest walls because they're just having to pump blood from the top chambers to the bottom chambers. With the ventricles having the thickest walls because they're having to pump blood out of the heart. Now the right ventricle only has to pump blood to the lungs, so that's a shorter distance. But the left ventricle, it's going to have the thickest myocardium because it has to pump blood all throughout the body. So it has to be strong enough to generate enough force to do so. Let's have a look at the different types of cardiomyopathy, so a condition affecting the myocardium of the heart, and we'll look at restrictive cardiomyopathy first. This is characterized by restrictive filling and reduced diastolic volume of either both ventricles or just one. So really, let's look at the left ventricle as an example. The left ventricle here is not allowing for the normal filling to occur from the left atria. So normally there should be an appropriate amount of pressure during that diastolic phase to allow for filling. But it's resistant to that. It's becoming non-compliant. And because of that, it can end up causing sort of a backflow into this left atria where it starts to become dilated. And so this is a widened area here. Let's compare that to normal. So if you look here compared to here, it's dilated. So the diastolic function seems to be affected with restrictive cardiomyopathy, but not necessarily the systolic or the contraction function of the heart. So the wall thickness is the same. It can still contract, so those myocytes are still functioning, relatively properly. But the myocardium becomes more rigid and non-compliant to diastole. Restrictive cardiomyopathy can mimic restrictive pericarditis that we spoke about before. With this condition, it's usually caused by something that infiltrates the area, some condition that causes substances to infiltrate the area, causing a restriction in the normal function of diastole. Hypertrophic cardiomyopathy. In this case, we have the left ventricle in particular, that seems to be most susceptible to this, hypertrophies. Why does it hypertrophy? Well, somebody could have untreated hypertension, and we've talked about this before, where they've had high blood pressure for such a long time that the heart has to work very hard, and so it gets bigger, the cells get bigger to do the work. And so we can see the enlargement of the left ventricle here. Contractility is still considered normal, but what I want you to make note of is that there is this overall reduction in the amount of volume that can fill that left ventricle because it's so big. So the muscle is so big, it reduces the size of the chamber. So again, because that left ventricle gets larger, it hypertrophies, it reduces the volume within it. Contractility, however, is still normal. Finally, dilated or congestive cardiomyopathy. This is where we have an impact in systolic function, the contraction. We talked more about diastole up here. And the reason that the systolic function is reduced, or its ability to contract, is because the wall becomes very stiff. So stiff that it can't contract properly. And if it can't contract properly, we're going to not be able to get as much blood out of the heart. And so we end up with an increase in volume within the heart chambers, intracardiac volume. And the longer this volume of blood is present there, and the heart keeps filling, it's going to increase pressure within that chamber. So here's showing you the left ventricle, which can over time lead to ventricular dilation. It widens, the walls start to weaken. And it does seem that the left ventricle is predisposed to this. You can see the dilation here. If we look up at this image here for hypertrophic, you can see how thick that muscle is. Now we're going to get into talking about conditions that can affect valves of the heart. And as a reminder, our heart valves, which are really these doorways that are going to permit the one-way flow of blood into the heart and then out, have particular names. We have the atrioventricular valves, which are the valves found between the atria and the ventricle. And the right side of the heart, they're called the tricuspid valve, and the left side of the heart, they're called the bicuspid or mitral valve. Then we have valves between the right ventricle and that pulmonary artery. So this would go to the lungs. That's called a semilunar valve. It takes on a semilunar shape. And more specifically, though, it's called a pulmonary valve because of its location in the pulmonary trunk. And then we have the other semilunar valves that are present between the left ventricle and the aorta. And they're also named appropriate for their location, aortic valves. They open to permit the movement, that forward movement of blood, and then they close to prevent any backflow of blood in normal, healthy hearts. Now that we understand the normal anatomy of valves, let's look at some disorders that can affect the valves. Valve dysfunction is really related to disorders of the endocardium. We know that the endocardium is that inner lining of the heart. And remember that this tissue is continuous to the valves. So disorders of the endocardium then damage the heart valves because they're made of endocardial tissue. In valvular stenosis, the valve orifice or the opening is constricted and narrowed. So let's look at that here. It's constricted and narrowed. So this is what open should look like. You can see it's constricted and narrowed here. And what this will do is impede the forward flow of blood from one chamber to the next and out of the heart. And so if we look here, in this example of stenosis of the mitral or bicuspid valve, the blood in the left atria is going to have a difficult time getting through this narrowed or stenotic opening. Has more difficult time getting blood, which really should be an easy process, moving it from the atria to the ventricle. And so this will increase the workload of, in this case, the left atria. It's going to have to work harder now to move blood past this diseased valve into the next chamber. And so the chamber of that, just proximal to that affected valve, can undergo hypertrophy and some of the other changes that we see when the heart muscle has to work harder than it should. In valvular regurgitation, also known as valvular insufficiency or incompetence, the valve leaflets, also known as the cusps, so the valves, they fail to shut completely. So normally, when blood moves from one chamber to the next, during certain stages of the cardiac cycle, the valves will shut behind like a door, preventing the backflow of blood. We want it moving in this one direction or in this one direction. But with valvular regurgitation or insufficiency, they're just not closing like they should. It's incomplete. And what this is going to do is permit blood flow to continue even after the valve is supposed to be closed. So what that means is we're going to end up getting, in this example here, the mitral valve is not closing completely. And at this stage it should, because we want it moving from the ventricle into the aorta and out the body. And so with it being open, it means one, we're going to continue to get filling during the cardiac cycle stage that we shouldn't, and we're going to get some backward movement of blood, and you can see it sort of pooling up here, whereas at this point it should all be through here until it's pumped out of the heart. And so try and picture this. If this muscle contracts here, normally with this valve being closed, when this valve opens, the heart will contract to push blood in this direction. Well, now there's another opening that's going to cause some blood to move back in this direction instead of in the forward direction that we want it to. And so the heart is going to have to work even harder to achieve the same job. So we have that increased workload, and we have potential hypertrophy. And remember also that anytime we have an increase in the volume of blood in any chamber over time, it can cause that dilation to occur where it widens, because the walls become weaker. Now this here is actually, I just noticed a typo in the textbook, in this version of the textbook, but this should actually say regurgitated valve, where you can see that it did not close completely and it's left open where it should be completely closed. So when you're studying, just make sure you know that that should say regurgitated or regurgitant valve, however you want to say, referring to this here. Okay, when the blood leaks back, when you're listening to somebody's heart, one of the what we're hearing when we listen to somebody's heart and we're listening for certain sounds, we can hear those valves closing. It's like a vibration created when the valves close. And so when valves are incompletely closing and we get that backward movement of blood, we call this, in terms of what we hear, or auscultation using a stethoscope, a murmur, which is a term I'm sure that you've heard in the past. So why does valvular dysfunction occur? Well, age alone can be a factor. With age and the changes that occur in tissues, they can become dysfunctional. Some people can be born with a valve disorder, and we would call that congenital. Some people can be born with a predisposition to developing a valve disorder. Or inflammation can be present that's associated with rheumatic heart disease, as an example. The most common location for valves to become dysfunctional when we talk about the 4 different types of valves is the aortic valve. So it's susceptible. That's one of our semilunar valves. And then the mitral valve, which is also known as the bicuspid valve or the atrioventricular valve. So really, we're saying that the valves of the left side of the heart are predisposed to valvular dysfunction. What sort of effects will we see? Well, the effects that we've talked about include effects on the myocardium and the chamber itself. So the myocardium, the muscle, can get bigger to deal with the extra workload due to the damaged valves. And because we're not moving blood in the normal direction, if it accumulates, it can cause the chamber or the ventricle, for example, to dilate. In terms of blood flow out of the chamber, we know it's going to be reduced for obvious reasons. So we have a decrease in stroke volume, which is going to lead then, of course, to a decrease in cardiac output. So just a bit of a summary here with valve dysfunction causing chamber dilation and myocardial hypertrophy. These are really initially compensatory mechanisms to deal with the changes, but ultimately they fail. The myocardial muscles cannot contract the way that they should, and there's a reduction in the amount of blood that is pumped out, so reduction in stroke volume and cardiac output. And we talked about the term ejection fraction, which is just the percentage of blood or the fraction of blood that is in the heart that is pumped out during systole. The increase in the amount of volume in the chambers, because we're not getting it out as well, can lead to or leads to an increase in diastolic pressure, more volume, more pressure. Ventricles will eventually fail from overwork, and it can lead to heart failure if it's not addressed. And it'll be varying degrees of outcomes and clinical manifestations depending on the degree of damage, where the damage is, what caused the damage, what the age of the patient, and the overall heart health of that patient is. It's going to vary what we see as a result of this state. Next up, we're going to look at infective endocarditis, remembering that endocardium is that inner layer that blood comes into contact with. Infective endocarditis is really a general term that's used to describe infection and inflammation of the endocardium, but it really impacts the valves as well, because we know that the valves are a continuation of the endocardium, so they're made of endocardial tissue. Bacteria is the most common cause of infective endocarditis. Which bacteria in particular? Staphylococcus aureus is the most common causative agent seen worldwide when we look at infective endocarditis. There's that itis referencing inflammation. The pathogenesis of infective endocarditis involves three critical elements. The first one is prior endocardial or valvular damage. So we're going to move up here. And what is it that causes endocardial damage? A variety of different things. Somebody can have congenital heart disease that causes damage to the endocardium. They could have valvular heart disease. They could have had some sort of trauma because they've had a procedure performed. Or maybe they had to have a prosthetic valve put in. And what's interesting is that there is a increasing incidence in North America of infective endocarditis because of the increase in implantation of prosthetic valves. So once endocardial damage occurs, it exposes the endothelial basement membrane. And this is going to end up attracting platelets, kind of like an injury would, right? Attracting platelets and stimulate a thrombus formation. But at this point, it's considered sterile, meaning it is not yet involving any form of bacteria. So we can call it a non-bacterial thrombotic endocarditis at this stage. Now, once we have this damage that occurs, blood-borne microorganisms are going to now adhere to the damaged endocardial surface. Now, how did the bacteria get into our blood to begin with? Well, it could have been from a variety of different ways. Just to give you one example, maybe somebody had a dental procedure that ended up causing bacteria to get into the blood. One of many examples. But in any case, there's bacteria in the blood, which we call bacteremia. Emia is referring to blood. So here's that state of bacteremia. So they're going to adhere then to that damaged endocardium, and they're going to infiltrate that once sterile thrombus. And they're going to accelerate fibrin formation. Remember, fibrin is part of that clotting cascade. Now we have the formation of vegetations, where we have sort of the clumping of bacteria and other substances in the area, and this can occur on the valves of the heart. When we've talked about embolization in the past, one of the types of emboli are vegetations. So these vegetations can end up impacting structures elsewhere in the body. Janeway lesions are these non-painful hemorrhagic lesions that you would see on a person's palms and the soles of their feet. And Osler nodes are painful red raised lesions that are found on the hands and feet. So Osler nodes and Janeway lesions are, we can say, cutaneous manifestations, so relating to the skin, cutaneous manifestations of endocarditis, most commonly from a bacterial infection. And then depending on the degree of damage and how the heart is responding to this situation, there can be a variety of other clinical manifestations that can occur as well. So I've talked about much of this already, with infective endocarditis being inflammation of the endocardium, that endothelial layer on the inner part of the heart, and most commonly caused by a bacteria that's in the blood. Now, how does the bacteria get into the system? Now, I gave you an example of a dental procedure before, but there are so many different causes. And if we look back on this slide, there's also a list here. So some examples include somebody that abuses intravenous drugs, someone that's just had surgery or had a prosthetic valve in place. I talked about that a bit already. People that have indwelling IV catheters they're in there for a long period of time. They're more likely to cause an infection. Somebody that develops a skin infection that gets into the blood, or somebody that is having to have hemodialysis done, which is the process of really purifying or detoxifying the blood when the kidneys are not working properly to do that on their own. Complications we talked about: emboli, thrombus, and then further continued damage of the heart valves, especially if the infection is of the heart valves, which is very common, and then altering how those valves function. You can see some of the vegetation shown in this example here. Now we're going to talk about rheumatic heart disease. We're going to go right back to the beginning, way before the development of rheumatic heart disease, and where it all starts. We've all had a sore throat before. Probably most of you have had strep throat, even if you were too young to remember when it happened. Strep throat is caused by group A beta hemolytic streptococcus bacteria, and it causes pharyngitis, inflammation of the throat. In most people, this will be treated with antibiotics successfully and it will be cleared up. But in some people, either if it's not treated with antibiotics or it's just not a successful treatment for whatever reason, it can lead to a condition called rheumatic fever. Rheumatic fever is a systemic inflammatory disease that's caused by this sort of unusual immune and inflammatory response to the bacteria. So it's how our body responds to this bacteria. Rheumatic fever will, in those that are genetically predisposed to developing it, rheumatic fever will occur weeks after a strep throat infection. And it's characterized by inflammation of the joints, muscles in your body, nervous system. Your heart can be affected, your skin can be affected. And once this happens, it needs to be treated quickly. Because if it's not, if rheumatic fever is not treated effectively and quick, it can progress to what's called rheumatic heart disease, which is scarring and deformity of the heart structures. So what is this autoimmune response, this delayed and exaggerated immune response that's happening? Well, in those that are susceptible, there's this abnormal response to the M proteins that are part of this bacteria. And it causes this reaction in healthy tissue. Our body attacks our own tissue, and we know that that's called autoimmunity. And so the areas that are attacked, as already described, are places like the heart, joints in the body, your skin, your nervous system. They can all be attacked in this autoimmune response. What's very important for you to understand is that rheumatic fever and the resultant rheumatic heart disease only occurs from a pharyngeal throat infection by this bacteria. In other words, if this bacteria was found on other areas of the body and wasn't treated, it would not cause rheumatic fever and rheumatic heart disease. Let's say somebody had developed rheumatic heart disease because they had unresolved rheumatic fever. Rheumatic heart disease can affect all three layers of the heart. Remember, the inner layer, that middle layer, and the outer layer. So the endocardium, myocardium, and pericardium. The most common location is the endocardium, leading to endocarditis, which can also affect the valves and promote vegetations, as we've already talked about. Now, if inflammation starts to move more externally and ends up impacting or penetrating the myocardium, the muscle, then localized fibrin deposits can develop that are surrounded by an area of necrosis. I'll say that again so you don't have to rewind it. If inflammation penetrates the myocardium, then localized fibrin deposits can develop that are surrounded by areas of necrosis. And these deposits that I'm referring to is called an Aschoff body. Depending on the extent of the myocardium being affected, it can impact the normal conduction of the heart. We'll talk about an example being atrial fibrillation in a bit. Another effect that can be seen is called cardiomegaly, and this is an enlarged heart, but not in the way you might think of with hypertrophy. Instead, the chambers can become so dilated that the heart appears larger. The heart can be impacted enough that it fails to function properly. Finally, it can penetrate the pericardium, that outer layer, causing what's referred to as fibrinous pericarditis. And this is where you have so many fibrin deposits that it really is similar to constrictive pericarditis, as we spoke about before, because it's constricting the heart and its normal ability to pump. So let's look at the conduction system of the heart, a few reminders of normal anatomy, and then we'll talk about some abnormal states. Normally, we have these specialized cells of the myocardium that are going to regulate the contraction of the heart muscles. And we have these signals that are going to be generated by the SA node that are going to travel and depolarize the atria and then travel down and depolarize the ventricles. And after they're depolarized, then they will contract. That's like their signal to contract. And when stimulated to do so, the two atria contract at the same time, and then the two ventricles will contract at the same time afterwards. It's a double pump. Usually when we talk about blood flow through the heart, because we can't talk about two things at the exact same time, we'll talk about the movement through one side and then the other. But it's important to know that those top chambers contract at the same time, and then those ventricles, when stimulated, will also contract at the same time. So we want a normal rhythm, but there are abnormal rhythms that we call dysrhythmias, also known as arrhythmias. In mild cases, and it's quite common, somebody might have a more rapid heartbeat here and there, or they might what we call skip a beat. In more severe cases, the dysrhythmia can be enough to affect the pumping ability of the heart. And so if that SA node's not working properly, somebody might need a new SA node in the form of a pacemaker. If the normal rate of our heart beating is affected, then, as you know, it's going to impact how tissues are going to be perfused with oxygen. What's the cause? There's so many different potential causes of dysarrhythmia, but they can be sort of generally categorized as there being some sort of abnormal rate of impulse generation, but there can also be an abnormal impulse conduction. So even if it's generated okay, is it able to be conducted throughout the atria and throughout the ventricles? Some common dysarrhythmias include sinus tachycardia and bradycardia. These mean different things. These have to do with your heart rate. Tachycardia is an increased heart rate. Bradycardia is a decreased heart rate. So we're talking about above what is considered a normal heart rate or below what is considered a normal heart rate. And that's influenced by the SA node. So it's either really underfiring or overfiring. Ventricular asystole, this is a state where the ventricles are not getting the impulses properly, and it can cause then the ventricles not to be able to contract. Because in order to contract, it needs to be stimulated. So if there's a cessation of electrical activity, then there won't be a contraction that follows it. And that would cause death. So cardiac arrest. Atrial or ventricular fibrillation. Although these are written together, they are very different, not just in where they are a problem, but in which one is more serious. In either case, though, the myocardium of the atria or of the ventricle is not fully contracting properly because of an abnormal rhythm. And so it's not a full contract. It's sort of at times it'll vibrate or maybe twitch, but it's certainly not efficient to do its job. Which one is more serious? Absolutely ventricular fibrillation. It is a serious medical emergency, and if it's not fixed immediately, a person will not survive. Whereas atrial fibrillation is different. You can survive with that condition. but there's still risks to having atrial fibrillation. Somebody that has atrial fibrillation, so we're talking about these ventricles that are not contracting properly. The muscle fibers are not contracting like they should. It's irregular. But some blood will still enter the ventricles, even though the atria are experiencing that abnormal electrical pathway. But because they're not contracting properly, blood will sort of move turbulently throughout the atria. And we've talked in the past about how turbulent blood flow increases your risk of clot formation. And if a clot leaves its location, it becomes an embolus. And it can be thrown from the heart to different areas of the body. It can be thrown from the heart to the brain and cause a stroke, as an example. So people with atrial fibrillation, although they can live with it, it needs to be treated so that they don't end up having, for example, a stroke. Ventricular fibrillation, as I mentioned, is far more serious. It's oftentimes called VFib for short. So if you watch any medical dramas at all, I'm sure you've heard on a number of occasions during an emergency, oh, he's in VFib. VFib is ventricular fibrillation and needs to be treated immediately. Commonly occurs in the left ventricle and very, very serious when it does. Your left ventricle is not able to pump blood out to the rest of the body, so your organs are going to experience hypoxia. When the left heart is failing to pump, it can lead to pulmonary edema, going back to our heart failure lecture. And in order to save this person's life, they will need to have the rhythm reset to normal using a defibrillator. So fibrillation is abnormal. A defibrillator will get rid of that abnormal and reset the heart rate in fortunate individuals. On our final slide on this topic, we're going to look at some blocks that can occur of impulse conduction. So normally when the SA node generates an impulse and it's sent through the atria, then it's going to reach the AV node. It's going to travel through into the ventricles. What if it's fine here, it travels through fine here, but then there's a block somewhere else and it can't move past that block? Then we're not going to get stimulation of those muscles for subsequent contraction. So somebody that has damage to the heart can have an effect on their conduction pathway, where the electrical impulses may not be able to progress to the next section of the heart. So we call it a block. It's an interruption. And a block can occur in different areas. But if there is a block that occurs along the interventricular septum, so this is the interventricular septum here, the division between the two ventricles, interventricular, in between, there's a septum. If there's a block here, then both the right and the left ventricle are not going to get their stimulation from the impulse in order to then contract. That is the end of this lecture covering various different heart disorders. Thanks for your time. Bye for now.